So those were some terms, and let's get to node architecture. So how is the node done? And we're going to talk about node architecture, then we're going to talk about lymphadenopathy, and I'm going to then put it together a bit. So with a lymph node, I'm going to draw a lymph node. There are some important parts, okay? So this is a paracortex. This is a cortex. And this is a medulla. And you got different cells over here. So we're going to start with the follicle. So typically, and this is a follicle, of course, and if it's activated, then you'll see. Also, this is mantle around it, and then in some lymph nodes, you could see also a marginal zone. Okay, and what do we have in follicle? Well, there are many cells, many important. Of course, what cells are there? Well, they're B cells, of course, B lymphocytes. They're naive and they're waiting for activation. Okay, so they're B lymphocytes. Then there are dendritic cells. But watch out. These dendritic cells are special. These are called follicular. So a better term is follicular dendritic cells. And they don't originate from hematopoietic tissue. They originate from mesenchymal tissue. And they don't have, there is no CD4 on them. Some of the dendritic cells that come from hematopoietic lineage, they can have expressed CD4, but not these. Okay, and I'm going to come to it very soon, but why I'm stressing it here. But then other ones you have there, you have the T follicular helper cells. These are CD4 positive. Okay, so you got B lymphocytes, follicular dendritic cells, helper cells, and still you got tingible body macrophages. And these are responsible for getting rid of the lymphocytes that went into apoptosis, that they were not selected to go farther and they were turned down because of not optimal affinity to antigen. Okay, so these cells are in the follicle in the cortex. Then you have a paracortex, and the majority of cells over there, those are T lymphocytes. And in medulla, you got what we call sinus histiocytes. And these are actually macrophages. Watch out. You got also histiocytes in the skin, but those are rather dendritic cells. But in majority, if we talk about histiocytes, we mean macrophages, but this could be a bit tricky in definition. But over here, those are macrophages, okay? So here are some cells mentioned in a normal lymph node and their locations, okay? And now, what about lymphadenopathy? Well, lymphadenopathy means that the lymph nodes and other lymphoid tissues will get bigger, okay? And will react to something. So in case of infections, whatever, now it depends what part of the lymph node enlarges or goes into hyperplasia, okay? And there are some general rules that someone could ask you, but it's not 100%, okay? But in most of the cases, because we know where the majority of B cells is and T cells is, we can sort of think it out, okay? But as an example, in case of typical bacteria, mainly, so typical bacteria, that means Streptococcus, Staphylococcus, Haemophilus, or even, let's say, rheumatoid arthritis, so autoimmune process. In this case, rather you should imagine that the cortex would expand, okay? There's going to be cortical hyperplasia. In case there are viral infections, in case of EBV virus, that means in case of mononucleosis, don't forget that the cells that are infected are actually B cells, B lymphocytes. And the ones that look different, are atypical, and were called the mononucleosis cells, those are reactive CD8 positive T lymphocytes. So to repeat it once more, so EB virus primarily infects B lymphocytes, but the expansion of the paracortex, okay, or let's write paracortex over here, paracortex, that is due to secondary reactive T cell proliferation, okay, so that's the one. And if we go farther, unfortunately, in case of cancer drainage, so for example, if you have a cancer, breast cancer, so if you drain the cancer, if the lymph node it drains the cancer, typically the medulla will expand thanks to the macrophages over here. And you don't have to have metastasis over there. It's just that the remnants of the lysed cells or whatever and antigens come to the lymph node, and typically the medulla is enlarged. But then you have some viruses and still bacteria that will expand both of them. And over here, basically, what I would stress here is the HIV virus. Remember, HIV is crucial because in many cases, and remember, if HIV is untreated, 20% of people in like lifelong expectancy is almost 20% will get a lymphoma. So HIV is very much connected with lymphomas, and even more with the combination of EB virus, okay? So, for example, HIV typically increases, paracortex and also cortex, okay? And sometimes more cortex, it depends. But why? I'm going to have a small talk about HIV and lymphadenopathy, which is crucial. Basically, in HIV, the early stages, they're typical with lymphadenopathy. And we'll still didn't talk about painless and painful lymphadenopathy, but in this case, it's painless. Okay, so, but maybe that I shouldn't forget it. So let's talk about the good thing about these infections, the bacterial ones before. I mean, we mentioned if you have a strep or staph, it means it's going to be painful. So painful lymphadenopathy is always better. You want in most of the cases, I'm sorry. So let's put it here like that. So if we want to divide, so if the lymph node is painful, that's pretty good because this is typically acute infection. Yeah. So strep or staph, that's okay. If it's painless, it's getting a bit more complicated because either it could be a chronic infection. So if we take as an example of HIV, at the beginning, in the first 2 to 4 weeks, that's a seroconversion phase, the lymph nodes can be tender, mildly painful, etc. So that's, let's say, very hyperacute phase. But when this switches to early chronic phase, that means like the first months to years, that's after seroconversion, the lymph nodes will be painless. And remember, in general, in chronic inflammation in general, so that means chronic infection or, for example, chronic autoimmune diseases, in this case, the lymph nodes are enlarged, so there's hypertrophy, and they're painless. But unfortunately, it could be also a cancer, so metastasis. That's painless, and of course, lymphomas like today. Okay, so this is a general view. Rather, if it's painful on touch, it's rather better than the other ones. Okay, but anyways, let's come back to the HIV and what I want to say over here. So typically, if you're infected with HIV in early stages, typically there's going to be lymphadenopathy, and it's painless, rather painless at the beginning. In late stages of HIV, and if a lymphoma will not develop, so that's more common, they actually get atrophic. Okay, so the lymph nodes are typically smaller. So first they're big early stages, okay, but late stages lymph nodes are small. They are atrophic, and of course, why? Well, because you're losing the CD4s. Okay, so they're atrophic. But the exception is if lymphoma develops, of course, then they're going to be big, okay? But how is it with HIV? So what I want to mention over here, that HIV, typically, what does it do? Because we got CD4 over here, it's a reservoir for HIV. So intracellularly, the HIV stays. So it's one of the biggest reservoirs, not the main one, but it's a very important reservoir of HIV. Not only this, but another reservoir actually are the dendritic cells, the follicular dendritic cells. Okay, but they are not entering the cells because they don't have the CD4s. Remember I told you. But what is important? The HIV is bound to their wall through complement. And again, they're shielded and the virus is hidden there against immunity and everything. Moreover, because these are dendritic cells, what they can do, they can actually give HIV to CD4 positive lymphocytes. So this is the way how the HIV stays in the body, one of the major mechanisms. And also over here, we can see how it is crucial that lymphomas develop over here in the lymph node, thanks to HIV. So if I would mention the T follicular helper cells, actually they are the central factor in viral latency. So those are the central factor of viral latency, but also of lymphoma genesis. Okay. And as I said again, or I don't know if I said it, but remember, without antivirotics, yeah, I said it, in lifetime, 10 to 20% of patients of lifetime will develop lymphoma. Okay. In contrast to that, with antivirotics, you decrease it to like 2 to 5% risk of lifetime lymphoma. Okay, so HIV crucial nowadays, and of course with the combination HIV and EB virus, this increases like this co-infection increases the risk, of course, a lot. Okay, yeah. So typically the HIV patients have like 100 times more risk. HIV positive have like 100 times bigger risk than HIV negative patients. Okay. Yeah. So that was a comment on HIV. And in case of HIV, it expands the cortex and pericortex. But still, I have some more special bugs over here for you, just to make it more complex. And still, I want to tell you about 4 pretty common atypical bacteria. So atypical bacteria, and I got Borrelia, I got Listeria, I got Bartonella, and I got tuberculosis. Okay, so remember this one causes no granulomas, but there's a hyperplasia of cortex typically. So no granulomas, and it's not intracellular. Listeria and Bartonella, they're facultatively intracellular. And Listeria typically causes non-caseating granulomas and expands cortex mainly. And then you have Bartonella, which causes, in some cases, non-caseating, but mainly plus caseating, and necrosis happens in the caseating granulomas and expands cortex, but also paracortex. And tuberculosis is obligatory intracellular. Causes caseating granulomas and expands cortex and also and paracortex. Okay? But where I am aiming that, cortex and paracortex and whatever, it's a different kind of lymphadenopathy, and that's in case of lymphomas, okay? And I want to tell you the difference. So thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.